different ride is in terms of growth monitoring in OPD practice, how we can do. I'm very sure that most of the ideas are thanks to Dr. Vaman Khedkar who has introduced this thing, and I may be making mistakes. So let's go by the IP guidelines. At birth, we should be aware. These are the just glimpses for we general pediatricians who want to practice in 2 minutes growth. In my request to all is this particular now next few minutes are going to have a 2-minute OPD practice of growth. So for that, whenever you see for a child birth, look at the birth weight and the ranges. Again, there is a range, and that is one important part in growth. We should be knowing the ranges, we should be plotting the graphs, and we should be remembering when you are prematurity, when you are IUGR, when NICU stay, history of gestational diabetes in mother or hypothyroidism in mother, look at the growth for the next few years very carefully. It will pay you a lot. Again, I use these words: look up, look at the child's head. Don't forget to measure the head because it gives a lot of clear understanding, because head circumference has a direct correlation with the brain size and obviously brain function in the first year. Then look down. Don't forget to look down. That is another area we really miss. For look down for the dysmorphic features, we can pick up genetic disorders at a very early stage. We never practice this measurement of penis at birth. Very important point, which is going to give a lot of clue to pediatric endocrinologists like Khadilkar or Vajpayee or Madam. Undescended testes we should not be missing, and ambiguous genitalia. Why I'm saying in growth? Growth has two parts. One is physical and other is physiological. And these parts are covering the physiological. So look up and look down, and that gives the idea. We are all aware that the development is cephalocaudal from neck to legs, and we should be careful about that. Again, lots of measurements. And this particular slide is going to tell you when we should assess the growth. So every vaccine visit, don't miss it. Every time you look for the milestones, look at weight, height, and head size. And after a year, even before year, 1 year also, start measuring the chest circumference. So head circumference, chest circumference, and by the time child starts reaching the age end of pediatric child practice, we are going to look for the adolescent age, where we are going to look for the waist circumference at that time. Now, the first 3 years, this is a glimpse of what Dr. Khadika always likes us to remember. Above 90th percentile, below 3rd percentile. Plot it, height, weight, and head seven. Plot in the standardized, the Indian graphs, WHO graphs, whatever you are using. Sir is going to again discuss it in his presentation. But plot it, and if you find that the child is above or below the 2 SDs below the expected, then you need to worry about it. Crossing two major percentile lines. For example, in this particular child, before 1 year, the child was within the limits, but after 1 year, the child is, both these lines are giving the others up or downward sides, take it as an abnormality. Below or above mid-parental height. So mid-parental height, another thing which all these pediatric endocrinologist teachers, mother's height plus average and plus 13 centimeter minus, all that calculation you are all aware. So that about the mid-parental height, again below and above, we should be aware. In the first 6 months, where we pediatricians are really connected with our children, that time, do not neglect a weight loss or no weight gain. If it is happening for a month, 2 successive visits, and you don't find a good weight gain or you're finding a weight loss, you need to confirm whether the child is well fed or there is any other nutritional or medical disorder which is causing growth failure. And lastly, at the same time, in the next 6 months, 6 to 12 months, when everything is apparently okay, that is the time you should find whether there is, if there is the growth has arrested, take it as a red flag. So this is another red flag I wanted to take over here. Then IIP says the next 3 to 9 years, where you have to look at this triangle, the age, where the weight for age, height for age, and most importantly, weight for height. Why? Because this weight for age, height for age, and all these are age dependent, they're changing. But weight for height is age independent. What are other areas? The mid upper arm circumference and its ratio with the head, its ratio with height, skin fold thicknesses, maybe the thing which all those are greatly involved in pediatric practice. They can use this age dependent as independent. What is important? Select your parameters and work on there. And for that, put it on a graph, put it on a chart is must. Saying that they're okay for the age is not the good idea. Start putting it on the graph and the things matter. My personal experience in pediatric practice, when you give that 2 minutes time of putting the things on the chart, the parents get connected with you. And that connect is going to take you for a very good pediatric practice over the years. Now let's go ahead with the next part of the plan. Again, as in the first 3 years, height, weight, rate of growth less than 5 centimeters per year, height below or above middle parental height. Now comes the importance of BMI, the waist circumference, the waist hip ratio. I'm not going to waste time over here because we are coming with a very good and fantastic lecture from Dr. Khadilkar on that point. But BMI more than 85th percentile, BMI more than 95th percentile, and we are going to look of obesity. I remember when I passed my master's in pediatrics in way back, that time we were not discussing about obesity. We were discussing about undernutrition. But now is the time, especially in the urban society with lots of screen and poor exercises, obesity is coming picture. That is the reason the whole symposium is for obesity today. Again, the Tanner staging, the sexual maturity rating, start looking at the child from 6 years. If you start looking at that, by the time you look at 100 kids, 1,000 kids, you're going to pick up one precocious puberty. So what is the precocious puberty? For a girl, getting the secondary sexual characters before 8 years, the red flag should come in your mind. For boys, it should be 9 years. And if these two things are happening, let's take it a very important, because if you are able to pick up at that time, I'm very sure the pediatric endocrinology backup for us going to take care of these kids very beautifully in the next few years. But we need to, because we are the ones as a pediatrician going to pick up these points at an early stage. What happens in the last part now, the last few slides, we are again going to look at height, weight. We are not going to forget height, weight and all these measurements in adolescence as well, because adolescence, there's another growth spurt and we have to pick it up at that time. But now we have to go up to BMI. BMI becomes one of the valuable tools now in adolescent. And along with BMI, again, the waist hip ratio, the waist circumference coming that. Now, a child was arrested for more than 2 years. Now that's a red flag. I leave it to the parent always coming back behind that. Unilateral or bilateral gynecomastia in boys or hirsutism and menstrual irregularities girls is another red flag we should be remembering when you think of the adolescent pediatrics. And delayed puberty, boys with no signs of puberty after 16 years, and for girls it is no menarche by 15 years and no breast development by 14 years. We should think that we are having a problem with the growth development. With that, I end with a very simple concept: keep good records. I think I'm borrowed this idea from Dr. Khadikar when he used to say always keep records. Records is going to be tomorrow's currency. I thank you with listening to me, but without wasting more time, I want Dr. Vaman Khadilkar to come and deliver his beautiful lecture. Dr. Vaman Khadilkar.
Thank you so much, Dr. Sunil, for setting that stage beautifully. I think you gave such a beautiful general pediatrician's perspective and underlined the importance of growth monitoring. I think you made my talk much easier. So without wasting much time, I'll straight away start sharing my screen. So today the theme of my talk is actually going to be, first part I'll cover as Indian obesity related anthropometry parameters. And in the second one, I am going to touch base upon the 2017 Endocrine Society guidelines. I'm only going to speak about the important aspects of the guideline. The guidelines are huge. So let me start with a case. Here is a 12-year-old girl. Both parents are diabetic, and they come to you only with this single complaint of neck pigmentation. They are not worried about the child's overweight or obesity. This is the sole complaint. And often in pediatric practice, the complaint with which obese children actually come to you is not obesity. They come for something like pigmentation like this. In adolescent, as Dr. Sunil said, they'll come for something like irregular periods. They'll come for orthopedic complaints. They'll come often for micro penis, but that usually is buried penis. So typically this girl child here comes with this pigmentation. The height is 152, weight is 60, and the body mass index is 25.9. Now, as many of you already know, the Indian Academy of Pediatrics has got this app. This application is for use on mobile phones and can be used on Android as well as iPhone. The application will plot for you like it has done here. And you can see that she is pretty heavy. She's on the 97 percentile for weight. For height, she's on the 70th percentile. And for BMI, she's clearly above the red line. So the beauty of this app is that here, if you look on the third panel on your slide, it actually tells you that BMI is above the obese percentile. So you don't need any calculations here. The app will do it for you. So clearly obese child. Now, Sunil fleetingly mentioned about waist circumference. And please remember, as Indians, we have this thin fat phenotype. What does it mean? That at a lower BMI, our central body fat is much more. So taking waist circumference is critical. So we did in this child, and you can see that she is above 95th percentile on Indian waist circumference charts. Her waist is massive, 93. She already has impaired glucose, fasting, as well as she is in the impaired glucose tolerance zone. Her HbA1c is 7.8, which is high. And you can see she's dyslipidemic. She has high LDL, high total cholesterol, low HDL, and triglycerides are just within normal range. Her SGOT and PT actually suggest that she must have non-alcoholic fatty liver. So we went on to treat her with diet and exercise for 6 months. At 6.5 years, she has gained some height. Her weight has come down significantly. BMI has dropped, waist has dropped, and now the fasting as well as PP sugar are normal. Her cholesterol is still above 170 is the cutoff. LDL should be less than 100, so just above that. HDL is improving, and triglycerides are okay now. You can see on the growth charts, the parameters look much better. From obese, she has come into the overweight category now. Her height is more by about 2.5 centimeters, and the weight has come down. Now, what next? See, this is a typical story of a child whose parents are a bit motivated. They work hard. With diet and exercise, you see this. And once you praise them, they're very happy. They just disappear. But you shouldn't say bye-bye to such children. You should follow them up carefully, at least 6 monthly. But sadly, this child disappears and comes back to you at the age of 14 years. And now what you find is that no menarche. Again, they don't come back to you because she has put on weight. But they come back to you because she still has not had menarche, whereas most of her friends have got menarche. You find that the secondary sexual characters are well developed. She has acanthosis, waist has gone further up, weight has gone further up, BMI is massive now, 29.3. She's hypertensive, her cholesterol has gone way above, LDL is high, triglycerides are high, and HbA1c is 8.5. And now her USG shows bilateral polycystic ovary. Please remember, PCOS can present as primary amenorrhea in children. Now, sadly, the graph looks worse. She's really obese. Again, the weight has gone up. Height is almost static now. And if you look at the serial plotting, this is where the importance of serial plotting comes. You see this drop in the weight and then gain. Same drop in the BMI and gain. This yo-yo phenomena is pretty bad. Any child who loses weight steadily is likely to have a higher chance of maintaining it. But sudden loss, sudden gain, yo-yo is a bad news. Now what next? We counsel, gave diet and exercise advice again. Started her on metformin because she's now in the diabetic range. Twice daily. She lost 5 kg in 3 months. Now she started menstruating. Her lipids and sugar remain abnormal. Now, in a child like this, please remember the prognosis is pretty good because of the yo-yo phenomena, frequent swings of weight, dyslipidemia at a younger age, and already type 2 diabetes. So for such children, the prognosis is poor and prevention was much, much necessary at a much younger age, and I'll come to that in a minute. So coming down to obesity after that case, obesity is a pandemic, you heard it. But importantly, it is the most neglected pandemic at a personal level, family level, clinics, schools, and society in general. But it has very significant impact, health consequences. These are the frightening data from India in 2016. And you see here in some parts of Delhi, it is as high as 30%. Some parts of Bombay, it is as high as 30%. So the prevalence of overweight and obesity has gone up significantly from 2000 onwards in Indian urban as well as rural setting, but it is much more pronounced in urban setting. And this cartoon from Hemant Morparia, which I had shown earlier, and some of you might have seen in some of my slides, is that this is the typical situation of an Indian affluent family today. That very aware mother, she is like a lollipop, a thin lady, and the kids are eating out. And she says, pizzas, colas, burgers, candy. The kids pig out when we go shopping. And the gentleman says, yes, they surely look malnourished. So this is the culture of eating out. Food considered as a symbol of prosperity. India is one peculiar country where the affluents are obese. In the rest of the world, it is the underprivileged who are obese because they have wrong choice of food. So this is the double burden of malnutrition that we have in India. Undernutrition as well as overnutrition. But please remember that obesity is a lifestyle disease. Now, how to assess obesity in childhood? You just heard Dr. Sunil say BMI is the most practical measurement. And Dr. Anurag has done a lot of work on this in Indian children along with us. And we both have found out that despite all the measurements that we use, perhaps BMI is the best measure as far as predicting risk factors are concerned. What BMI cutoff do we use? Now, please remember that in children, the BMI cutoff change with age. Because children grow, you can't use a single value. So you have to use charts. And again, more importantly, the cutoffs are also age specific. So if you look at this, for children who are less than 2 years, the WHO has actually said that you have to use a much higher value for obesity, 97.7 percentile. And above 90th percentile is considered as risk for overweight. Whereas children who are older, we use IIP growth charts and we use more than 23 adult equivalent as overweight and more than 27 adult equivalent as obese in IIP charts. Whereas if you use CDC or WHO charts, it's 85th percentile and 95th percentile for older children. But please remember that these values are much higher than what are desirable for Asian children. So we strongly recommend to use IIP cutoffs. Now, you know that these are the charts which are derived from this paper, and these are color coded. The orange line is for overweight and the red line is for obesity. Same for girls here. So it's very easy to use BMI chart. You just look at the BMI on the age scale here. Anybody above orange has overweight and anybody above red line is obese. Now, recently in fact, we published this paper in 2011. Based on this, actually, the IIP growth charts cutoff were decided. But what we have shown is why are we lowering this cutoff from 25 that the whites follow to 23 for Asians? What you see on this graph is on the x-axis, you have the BMI cutoffs. And on the y-axis, you have the percentage of metabolic syndrome risk factors. And you can very clearly appreciate that when you lower the risk from 23 to 25 to 23, this particular column, the second column, there is a sudden increase in the metabolic risk factors. Whereas below 23, the metabolic syndrome risk factors are minimal in Indian children. So therefore, this makes logical sense to lower it from 25 to 23. 25 is an okay like cutoff Caucasian children who have a much lower body fat at the same BMI. So when we lower the cutoff from 25 to 23, we pick up many more children with metabolic syndrome risk factors. Therefore, 23 cutoff seems quite safe for screening Indian children using the IIP charts. Now, this year we published this paper in Indian Pediatrics, Body Mass Index Quick Screening. Now, we know as pediatricians are very busy people, we do not want them to calculate stuff because when we add a factor of calculation, it gets omitted. So we published this tool and it's very simple. All that you now have to do is look at the height on the x-axis and weight on the y-axis and just plot it. This is for boys, this is for girls. Please bear in mind, this is applicable for children between 8 and 18 years where metabolic syndrome becomes more and more prevalent. So let me give you an example. Here are two examples. These are our IIP growth charts. The black dot is a child who is normal who has a height of 135 centimeters and a weight of 30 kilos. And the red dot is a child who has a weight of 35 kilos at the same height. Here you can see that this child is normal on IIP growth charts and this child is overweight. Now using the BMI tool, see, it is that quick. All that I did is 135 centimeters and 30 kilos. Here is your patient who is normal. And the second child, 35 kilos, falls in the overweight category. So I have now removed the calculation bit from the pediatrician's office. So it takes less than 5 seconds to plot it, whereas that calculation takes more than half a minute. Now, waist circumference in Indian children, a very important parameter for central obesity. And you can see here that this paper was published in American Journal of Pediatrics in 2014. And we have been able to establish norms of waist circumference for Indian children. And these are the graphs where you can actually appreciate the percentiles. And NHANES says that use the 95th percentile as cutoff. But in our study, we found that even at 70th percentile, you get more children with metabolic risk factors. These are the charts for girls, and the same findings are true here also. And now what this graph is showing you, that body composition of Indian children is different. And what I have shown here is comparison of Indian boys and Indian girls body fat percentage and lean body mass as compared to the rest of the world. So the rest of the world has much higher lean body mass and much lower fat mass. And in Indian children, it is exactly reverse. So using the DEXA, we have published this paper on body fat percentage. And not to take you through the table, but I've simplified this into this call out, which says that the 85th percentile of body fat in Indian children is 28.8% for boys and 42% for girls. Whereas the same numbers for white children using McCarthy's values are just 20 and 30%. So for the same body mass index, we are having much more adiposity. So lowering BMI seems to be very logical. Now, in a school setting or even in a busy clinic setting, lifting pinafore of a girl who is adolescent can be difficult. So is there any other surrogate marker that we can use other than waist circumference? So wrist actually works as a very good surrogate marker of insulin resistance and hypertension. So if you use wrist just to screen a child, we have now established the wrist circumference percentile for Indian children and the same parameters here. See the wrist circumference of Canadian children in red and the wrist circumference of Indian children in blue. We are having such thin wrists, but at the same time, the 70th percentile of our wrist actually correlates very well with insulin resistance and hypertension. So if you're too busy, just use the 70th percentile of what norms that we have established. Now, metabolic syndrome. Metabolic syndrome can be defined only after 10 years or after puberty is established, whichever comes earlier, because you now know that some girls start showing breast development at 8.5 years. So you can use the metabolic syndrome norms. And why are Indians more prone? Because of our intrauterine programming. Our babies are small, they are malnourished. So there is an adaptation to intrauterine environment. So they have liver, which is smaller. They develop insulin resistance as a protective mechanism. The number of beta cells in the pancreas are less. And they also have abnormal vascular development. Then comes the obesity. So you're born small, you're programmed to be small. Then comes surfeit of calories and obesity. And what was adaptation becomes a disadaptation. So you develop dyslipidemia, diabetes, hypertension, and the entire works of metabolic syndrome. So this is the intrauterine programming followed by the surfeit of calories. Two together would lead to metabolic syndrome in Indian children. Now, this is the most accepted definition of metabolic syndrome. And as you can see here, that you ought to have central obesity. So you either use the NHANES 90th percentile, or in places where national percentiles are available, you should use them. And presence of 2 or more of the following. Like in the girl that I presented earlier, hypertriglyceridemia, high density lipoprotein low, high blood pressure, and fasting sugar more than 100. Any 2 of the 4 plus central obesity is metabolic syndrome. So my simple approach to a child, Indian child who is obese, is if the BMI is more than 23, or if the waist circumference is more than 70th percentile, and if there is a family history of diabetes, hypertension, cardiac event, or stroke, then check lipids, glucose, insulin, HOMA, HbA1c, and BP. Now the insulin, whether you should measure or not, is a matter of contention, and I'll show you that in the short guidelines that I'm going to present as last few slides. If normal, then don't say bye-bye like that girl disappeared. Keep checking every 2 yearly in all overweight children. And if they're already abnormal, then you have to start the lifestyle modification. In children who have type 2 diabetes, you should start metformin. Pharmacotherapy and bariatric surgery, we will come to that in a minute, but generally I would say no. And also look for comorbidities in this group. Now, in this month's Indian Pediatrics, we have published these pediatrician-friendly growth charts. And as you can see, these are actually IAP growth charts to which 2 more tools are added. Here, the BMI screening tool, where no calculation is required. And here, the mid-parental height calculation tool, where again, no calculation is required, is added. And we do request you to use the charts. They can be downloaded from the IAP website. They're free to use. Now, these clinical practice guidelines were published by the Endocrine Society in 2017 for pediatric obesity. And there are certain things that I would like to highlight. That for children who are less than 2 years of age, use higher cutoffs, as I mentioned. For older children, we use the race ethnicity specific IAP cutoffs. Now, it is important to calculate BMI and plot it regularly. Second step is very important. No endocrine evaluation is necessary unless the patient has short stature or height velocity is less. So if you have a patient who is short and fat, you must then evaluate for endocrine obesity. Otherwise, don't unnecessarily investigate. Overweight children or adolescents should be evaluated for potential comorbidities. And the guideline actually says that unless there are clear-cut signs of insulin resistance or family history of diabetes, or specific risk factors, do not measure insulin in every child who is obese. Now, the guideline also tells us which are the children who can have genetic obesity syndromes. So patients who have extreme early onset obesity below 5 years, then clinical features of genetic obesity syndromes, particularly extreme hyperphagia, a family history of extreme obesity which is intergenerational, then you should think of monogenic causes of obesity. In prevention of obesity, there is a holistic approach that has been advocated, and clinicians should promote and participate in ongoing healthy dietary and activity education to children from a very young age. This should also be extended to parents and communities, and we should encourage schools to provide adequate education about healthy eating. Now, avoiding consumption of calorie-dense, nutrient-poor food has been emphasized tremendously, and IIP is also taking a lot of steps to actually improve this. Children and adolescents should engage in at least 20 minutes and ideally 1 hour of vigorous physical activity for at least 5 days a week. And please remember, this is for prevention. For treatment, this amount doubles. Encourage breastfeeding, encourage healthy sleep pattern. Early to bed, early to rise is important. Limit technology-related screen time. Now, sadly, in India, schools have gone online, so that 3 hours has become mandatory. But beyond that, we should prevent it. And it's a family affair. The entire family should follow the same principles. And school-based programs should be encouraged for weight loss, and behavior modification programs are the sheet anchor of treatment of prevention and treatment of obesity. In obesity treatment, it should be lifestyle modification, which are dietary, physical, and behavior. The same thing which I mentioned in prevention have again been mentioned in the treatment. But they have very clearly said that no fruit juices, but fruits where you actually consume fiber along with fruit juice. Now, portion control. We must teach our children to take smaller portion, to take smaller plate, to eat slowly, and to avoid stimulus. So stimulus control is something that we have to teach our children. And avoiding constant grazing should be taught. No in-between meal snacking. 60 minutes of rigorous physical exercise, screen time not more than 1 to 2 hours. And now with schools going online, I think we should say nothing after school hours. And family should start supporting the child in terms of self-esteem. See, a lot of these obese children and adolescents have a very poor self-esteem, and that further leads to food as solace. So that cycle needs to be broken. Coming to last couple of slides, pharmacotherapy for children and adolescents with obesity should be avoided at all cost. Metformin should only be given in children who have type 2 diabetes, not just for insulin resistance. And clinicians should discontinue medications if used in adolescent and re-evaluate the patient if there is less than 4% reduction in the BMI after 12 weeks of medication. But please remember, medications are only meant for cases which have pathological hypothalamic hyperphagia, and generally in childhood they are not used. Bariatric surgery, very strict criteria. It should not be done in children. It may be considered in adolescents who already have become like adults at Tanner stage 4 or 5. They have reached the final height. They're morbidly obese with BMI more than 40. They have comorbidities, at least 2, such as hypertension, dyslipidemia, sleep apnea. So extreme obesity and comorbidities persistent despite compliance to a formal program of lifestyle modification and pharmacotherapy, then only considered bariatric surgery. And psychological evaluation confirms the stability and competence of the family to deal with the surgery, then only bariatric surgery. We have a lot of bariatric surgeons today telling you to get children operated at a younger age, but I think you should all prevent that. So these were the guidelines which have been published, and I think the message is very clear that no pharmacotherapy and no bariatric surgery for children. Once again, the pediatrician friendly growth charts, and I think we should make more use of them. So my take home message are obesity in children is a pandemic. It is a lifestyle disease. Primary hormonal problem causing obesity is rare. Secondary hormonal problems, metabolic syndrome and insulin resistance are common. Indian obesity, waist, risk and other body parameters are different, and we have established some national norms which people may use. Behavior modification, lifestyle interventions are the sheet anchor of prevention and treatment of obesity, and pharmacotherapy and bariatric surgery are not advised before late adolescent, only when associated with extreme obesity that is resistant to treatment along with comorbidity. So those of you who are interested in reading pediatric endocrinology, the IIP textbook on pediatric endocrinology is available. And recently, Dr. Anurag, in fact, only today has also published IJP, a pediatric endocrinology book. So thank you very much for your patient listening, and I'm happy to answer any questions should there be some. Thank you.
Thank you, Dr. Vaman Khedekar. It's always a pleasure listening to him and having a very clear-cut guidelines for the time and for what you are going to do, go ahead with the. For the sake of time management, we'll keep all the questions together for that panel discussion where we are going to all expecting all the 3 people joining together and answering at the right way. I think we can call now Dr. Anurag. Dr. Anju madam is also joined. I'll ask her for, because in the sequence she was thinking of Dr. Anurag was requesting. Dr. Anju, can you
good evening.
Unmute yourself?
Good evening, everyone. Hello, Anurag.
Dr. Anju said.
Vaman, everybody. Sunil.
Yeah.
No, I'm good. And it's Anurag's turn. Let him speak. It will be a pleasure to listen to him.
No, madam, actually, Dr. Anurag was requesting you to be the first because you may set that stage for his discussion as case scenario.
I think
is it possible for you, madam, to start with your presentation?
So I think I can carry forward from there.
Whatever you say is okay with
me. It's okay. So, Dr. Anurag, let's continue.
Dr. Anurag topic already, so it is much easier for me to now carry forward from there.
Yeah, then let's continue the same line. Dr. Anurag Bajpai, the next stalwart to answer. Thank you, madam.
Sure.
Okay. Thanks a lot, Dr. Sunil, and thanks a lot, Dr. Vaman, for making my life much easier in terms of these aspects of evaluation. So what I'm going to do today is to really go through with regards to some of these case scenarios which we encounter in daily practice and how we interpret in the light of science and go back and evaluate in that regards. Now, Dr. Maman has already mentioned that obesity is a big problem. We are probably going to handle around 10 to 15% if we talk about affluent schools. So it's a big issue. 98% of these are actually physiological. They do not have any pathological cause. Only 2% have a disease. So the big burden that a pediatrician has to focus is to not unnecessarily evaluate for pathology, which Dr. Bowman very clearly said in these 98%, while not missing those 2%, and very importantly, look for complications in these individuals in that perspective. Now, if you look at obesity, it is most likely physiological, 98%. It's associated with normal growth, puberty, and development. Pathological causes are rare. So if you are talking about a genetic or syndrome causes, usually rare, but associated with significant hyperphagia, vision, and pubertal abnormalities. Secondary causes are associated rarely, and you can get the history of hyperphagia or drugs. And finally, endocrine causes very rarely, usually associated with growth failure. So essentially, if you have a child who has a normal growth, normal puberty, and normal development, you don't need to really bother about with regards to a particular pathological cause. Focus mainly in terms of lifestyle and evaluation from that perspective. Just to touch base upon and carry forward from where Dr. Vaman talked about obesity approach, of course, look at the three major things. Look at growth, puberty, and clinical examination. If everything is normal, you basically assess for complications, and we'll discuss that about a bit later in the form of glucose tolerance, lipids, and SGPT. If the growth is slow, think of endocrine, then do a thyroid profile and other evaluation. What's very important is that while hormones can cause obesity, obesity can also cause a number of endocrine problems. Obesity can cause subclinical hypothyroidism, it can cause growth hormone deficiency like picture, it can cause a Cushing syndrome like picture. So if you are doing unnecessary investigation in an obese child, you may actually result in a false labeling of an endocrine cause. These are some of the cases we will highlight. If, of course, there is a CNS insert, think of a hypothalamic pathology. If, on the other hand, it's an early onset with severe hyperphagia and a normal development, some rarer causes will come up. If abnormal development is there, rule out Prader-Willi syndrome and other aspects. So essentially, the most common arm you will be going through will be this 98%, rest are only 2% in that regards. So what I'm going to do today is to go from clinic to the bench in the form of how these all hormones are interacting, and then go back to the clinic and see how we can really understand and evaluate in that perspective in that regards. All of you are invited to visit my website, learning.growsociety.in, where there are a lot of resources available with regards to pediatric endocrinology in the form of videos, lectures, texts, a lot of courses also available. And you can have, that's learning.growsociety.in, and you can have a look at our mobile application, which really provides different diagnostic pathways, approach pathways, and we'll see how it works also in case. So we'll start off right with cases now. So we have this 12-year-old girl who presented with obesity. She had a height of 130 centimeters, was a bit short, weight was more, screening tests were done, which was basically normal, and then she was advised lifestyle measures. Now, this is a situation in which people will say, okay, 98% of these individuals have a chance of physiological obesity. Why do a workup? But there is a big catch out here. This girl is actually short, and that's a very important pointer here. Now, what happens in obesity when we go back to the bench is that once the weight increases, that causes insulin resistance, and that insulin resistance increases the IGF-1 levels by decreasing IGF-BP, causing increased growth. So obesity basically is an increased growth state because insulin increases IGF-1 and has a direct effect on IGF-1 receptor. So if somebody is obese, should be tall. If you have a short child with obesity, you have to be bothered. So if you have a child with obesity whose height age is more than the age, it basically means in this pattern you're seeing he's tall for his age, it is an exogenous pattern. But if you have a short child with obesity like this girl, you cannot label them as constitutional obesity. This is definitely pathological. And this is the one big message coming out of from this case clearly in that perspective. So when we assess this girl, she had a rapid weight gain and she had this endocrine pattern of obesity. And if we go through the growth interpreter, which is also based upon the IAP chart, it really gives a number of patterns, a number of parameters, and tells us what sort of pattern of growth failure we're looking at. So this really says it's the endocrine pattern growth failure, and the height SDS is actually more. So this child is short and plump. And if you have a short and plump child, exclude hypothyroidism, growth hormone deficiency, thyroid was normal, and this girl happened to be Cushing's syndrome. So while a large majority of these individuals will actually be physiological, pathological causes are there which we have to really look at, especially if there is an issue of growth failure. So obesity increases growth. If you have a short and a plump child, think of hypothyroidism, Cushing syndrome, pseudohypoparathyroidism, Turner syndrome, and other rarer possibilities, and height becomes absolutely important. Second case, a 12-year-old boy who is 160 centimeters, weight is 70 kgs, parents are average height, bone age is normal, and somebody does a TSH which is slightly elevated, 7.91, labeled as hypothyroidism and advised treatment. Now, this is one of the most common referrals we as pediatric endocrinologists get, and parents are also happy. The treating physicians are also happy that you found the cause, you treat it, and the child will be fine. What we need to understand is that this is not the cause of the disease, but the effect of obesity. So what happens in obesity is that when your fat is a lot, leptin becomes high, it goes to the hypothalamus and says, okay, let's burn some calories, and it stimulates the TRH, it stimulates the TSH, but that is it. The body then realizes that we don't want to burn the muscle and bone by increasing thyroid, so therefore the thyroid levels are normal. So this marginal elevation of TSH which happens in obesity is actually the effect of obesity and not the cause of obesity in that perspective. And this is a very common situation. No need to treat unless there is a goiter, unless there is a TPO positivity in that setting. So this is a compensatory reversible form, no treatment required. Now, if you look at this child and put in the growth interpreter in our app, what you're seeing is that this child is actually tall. And if you have a tall child with obesity, it's very, very unlikely to be having an issue with regards to endocrine cause. So this hypothyroidism is the effect of obesity and not the cause of obesity. And on follow-up, the levels were normal. Having said that, what we have really observed that hypothyroidism, subclinical hypothyroidism happens in around 30 to 40% of obese individuals. And this is from our study recently published of around 400 obese individuals. And it may predispose to non-alcoholic steatohepatitis. So it may not be entirely benign, but at the moment we are at an experimental stage. There is no need of treating somebody who has a borderline TSH and a TPO which is negative in that perspective. Now, very importantly, therefore, that mild TSH elevation is the effect of obesity. No need to treat if the TSH is less than 10 and the TPO antibodies are negative in that perspective. Now, we have a third case, a 14-year-old girl with obesity. Blood pressure was normal. There was some pigmentation which was there. Somebody thought this could be Cushing syndrome, and they found that the cortisol levels were high. Now, this is again a common thing. The cortisol was fine, and then they went ahead, did ACTH, which was high. They did a MRI, and they found a pituitary adenoma. And you have a diagnosis of Cushing's disease referred for surgical management. Now, as I said, only 2% of them will have a pathological cause, and Cushing syndrome is an extremely rare cause of obesity in children. There will be many other manifestations which are there. This child was not short. So what was going wrong here? What happens in obesity is that if your fat is more, you have got greater production of cortisol, and also there is increased effect of leptin as on TRH, also on the corticotropin releasing hormone, and the cortisol level goes up. So therefore, obesity is associated with what is known as a pseudo Cushing stage. As I was saying, obesity looks like GHD, obesity looks like subclinical hypothyroidism, obesity looks like Cushing syndrome. Do not get into the trap of it. This child should not have been evaluated for Cushing syndrome in first case. Once you have done that, there could be a lot of confusion which happens in that regard. So now what we look at is in this case, we should do a overnight suppression, which was normal, basically telling us again that the hypercortisolism here was the effect of obesity and not the cause of obesity. So definitely nothing to worry in this situation. Do not do this evaluation. It causes more confusion. So obesity can cause pseudo-Cushing's like disease. Biochemical confirmation is essential because otherwise 7% children will have incidentalloma and you will get confused in that perspective. And this is a big point to remember. So unnecessary endocrine investigations that Dr. Vaman was saying are not recommended in the setting of obesity. Now let's go further. There's a 7-year-old girl who presented with thelarchy. This is a very common presentation which we see. There was reportedly a breast stage 2. The height was normal. This girl was a plump child. The bone age was normal. The LH, FSH, and estrogen were normal. So why is this girl presenting to us with breast development apparently when there is no advancement of bone age and the hormones are normal? And this is a very, very common problem which we see in obese girls. Now, what happens in obesity is that obesity has an effect on leptin, and leptin is actually the gatekeeper of puberty. So if you have obesity, there is a chance that the puberty may happen early in girls, but when the weight becomes more, this becomes disrupted. So there may be early thelarchy, but menarche, as in Dr. Vaman's case, may be delayed, and this may result in what is labeled often as a PCOD-like picture. So this may be one of the reasons that because of obesity, she has developed early puberty. But as I discussed, when the fat becomes too much, the whole axis is disrupted, which causes a slowish, disrupted puberty in that perspective. But one important thing that you have to think of in an obese girl presenting with breast development is it really a breast development or is it a lipomastia? So all we did was we approximated our thumb and finger at the areola level and we tried to see if there was a resistance. She had a red vaginal mucosa. There was only fat. It was not really breast tissue. So this was not really a precocious puberty. It was an unnecessary false alarm. So as obesity can cause multiple false alarms in terms of endocrine disorders, it may also cause false alarms in terms of multiple other conditions like precocious puberty in girls, micropenis in boys, and rickets. And all these we'll discuss subsequently in clinical cases. The key messages are that obesity causes early but disjuncted puberty in girls, but beware of lipomastia. If you have got an obese girl, parents are concerned about the breast development, confirm it's really breast development and not really lipomastia in that perspective. Again, a very, very common presentation to a pediatrician, 14-year-old girl with hirsutism, menarche 1 year ago, periods every 2 months, similar to what the problems happen often, which is presented to gynecologist, mild level of hirsutism, which was there, ultrasound showed PCO appearance. And if any of these girls go to a radiologist, they always are very happy to write a polycystic ovarian appearance. And then these people are labeled for life for PCOD. Now, what we need to remember here is that PCOS in adolescents is absolutely different from that in adults. There is no role at all of a polycystic ovarian appearance in adolescents because ovaries are larger, they have got more number of cysts. Very importantly, in adolescents, there would be a physiological anovulation, there will be physiological hyperandrogenism. So the criteria need to be very strict. We need to have a high testosterone, moderate to severe hirsutism or severe acne, and age-specific criteria. So in the first year of life, if you have more than 4, in the first year of post-menarche, if there are 4 or more periods that are considered to be enough, and this really is not PCOS. 95% of patients who are unnecessarily labeled as PCOS just because of these polycystic ovarian appearance tend to have a normal course later on. So just because somebody is a bit fat, somebody has got some hirsutism, please do not label them as hyperandrogenism. So we have to confirm that this girl has a Fairman-Gallwey score of hirsutism less than 15. There is no other features of hyperandrogenism. So this is just a simple obesity. We need to work on weight. Don't label it as PCOD because that will have huge implications subsequently in terms of treatment and in terms of multiple other outcome issues. Now, 12-year-old boy with pubertal concern, and this is again, so puberty is affected both in boys as well as in girls. Height is all right, weight is on the higher side. He has got a slightly decreased penile size. Testes are prepubertal, but he has got a pubic hair development. So parents are confused. Pubic hairs are developing, but the testis is not developing. So what really is happening? So as in girls, obesity has a dichotomous effects on puberty. If you have got more obesity, estrogen will become more. This will suppress the LH level, so there will be delayed puberty from the gonadotrophy angle. But because of the insulin resistance, the adrenal production happens. So in that, testes are delayed, adrenals are fast, so there will be delayed puberty and pubarchy, and this is the disconnect which is happening in this case. DHEAS is high, so obese children, obese boys may come to you only with pubic hair growth with a small testicular and a penile size. Don't worry about this. This is a normal phenomena which will hopefully improve over time in that perspective. Another problem which very commonly comes to us is this 8-year-old boy with small phallic size. And this is again, as Dr. Vaman was saying, more children come to us with obesity associated pseudo symptoms like gynecomastia, like lipomastia and micropenis than actually obesity, because parents are happy with the way they are. Now, this child was really obese. He had normal testes. There was no other abnormality. And when we actually looked at the penile size after pressing the suprapubic fat, we found that there was a normal penile size. So this again is a red herring, a false alarm. Micropenis in most obese boys is actually buried penis. Please press the suprapubic fat, stretch the penis size, and then evaluate in that perspective. So in terms of puberty, there is a gonadotrophy adrenarche disconnect which happens in boys. Beware of buried penis, and I think this is a big message which I like to give. Now, going back to one rare case of a 3-year-old girl with rapid weight gain, and you can see the weight is 26 kgs, very huge, severe hyperphagia. This is one condition where we have to be bothered in that regards. And as Dr. Vaman has said, if there is an early onset obesity with hyperphagia, we have to think of a genetic cause, which happen to be the MC4 receptor defect. Now, monogenic causes of obesity are less than 1%, but onset before 2 years of age, rapidly progressive, or less than 5 years of age with hyperphagia, think of them in that regards and evaluate accordingly. A very interesting case which clubs both growth as well as development. 7-year-old boy with rapid weight gain, the height is compromised. There was infantile hypotonia and failure to thrive. So there is a developmental issue also, which is there. Now, suddenly there is a hyperphagia, which is happening. So what are we dealing with? I think the diagnosis is pretty clear. Basic workup was normal. If we go to our approach pathways, to go specifically on the obesity approach, so we are seeing that he is obese. There is no history of drugs. The development is retarded. Neurological insult is not there. You want to rule out pseudo-hypoparathyroidism, which is normal. The next diagnosis which comes is basically Prader-Willi syndrome. So all you have to do is ask for the hands, look at the face, and you will know this is Prader-Willi syndrome. So again, if the growth development is affected, think of syndromic causes, and Prader-Willi is an important one in that perspective. So the key messages from this case is that if you have an early onset hyperphagia, think of genetic causes. Family screening and hypotonia become important in that clinical perspective, and we have to think of workup. Now, what about the effects of obesity? We've been talking about the obesity effects on hormones. We have been talking about obesity effects on clinical manifestations. How does obesity affect the complications? So this is the mirror case of what Dr. Mawan presented. 16-year-old boy with obesity, BMI is huge, 46 kilogram per meter square, severe acanthosis, and again, he was given thyroid, which of course doesn't make sense in this situation. Now, what we need to understand is that if you have too much fat in the diet, the body has got a limited area to store that fat. And excess fat will go and deposit in the liver, and this will cause insulin resistance, causing fatty liver, resulting in a problem of type 2 diabetes, PCOD, and cardiac issues. Plus, you have mechanical problems like sleep apnea, sleep deprivation, benign intracranial hypertension, and not sleep volume issues. So obesity, we have to think of multiple effects across the body, which becomes absolutely important to evaluate. And this is our latest study, which was published recently of 311 children. We found that a large number of these patients, around 50%, had a significant metabolic complications, and older children with a family history of diabetes are more likely. So very important to evaluate them for glucose tolerance, particularly for fatty liver disease, for hypertension. This is something which we have to do in that perspective. So what happened to this child was that he developed type 2 diabetes, high SGPT, and a lot of problems happening. And as Dr. Vaman was saying, our hands are tied in terms of pharmacotherapy. Very limited treatment options are available. A 16-year-old girl with obesity, suddenly she starts to complain of pain in the leg and difficulty in walking. This is a common thing. Always think of a slipped capital femoral epiphysis. So if you have a child who is obese, difficulty in walking, knee pain, hip pain, do an X-ray. A common problem, particularly in obese adolescents, that we are observing in that situation. Last case, I think 14-year-old girl with worsening school performance. Obesity was there. She complained of snoring, daytime sleepiness, and episodes of binge eating. So a lot of these issues which come up in terms of eating disorders, bulimia, and all those problems are very common. So it's not just the medical issue. You have to look at other psychosocial issues as well. And if you have snoring and daytime sleepiness, always think of a sleep apnea in this perspective. And this happened to be sleep apnea and eating disorder in that perspective. So from a complication perspective, always assess for complications. Basic things are oral glucose tolerance test, lipid profile, blood pressure, and SGPT, very important. And be wary about slip capital femoral epiphysis, sleep apnea, and eating disorders. So if you summarize all the talk, you have to be wary that obesity can mimic subclinical hypothyroidism, Cushing's in GHT. So don't do unnecessary hormone investigation. It may also mimic micropenis, rickets, and gynecomastia and precocious puberty. So hold on to your investigations there, but do assess for complications. Do assess for a short child, short in developmental delay. Think of a syndromic cause. If there is hyperphagia, think of a genetic cause in that regards. You can all have a look at our learning.society site, which provides a lot of information. All this talk also is available there in a video format, and have a look at our application. Once again, I think thanks all of you for patient hearing, and we'll maybe discuss once we have the panel subsequently.
I think it's a great follow-up of what Dr. Vaman Khadekar has set the stage with. And with this case presentation, typically those people who are like us, who are working in the field, we are getting that connection with the theoretical part, the theory, what the pediatric endo is saying, and Dr. Anurag was setting up with the cases. And now again, we'll go back. We want Dr. Anju Madam to do what we can do in our pediatric practice and get the things the way the endocrinologists want. Because I always feel that we are doing something else and the endocrinologists are at other end and saying that what this particular pediatrician done and what to do about this thing. Dr. Anju said, I want Madam to just start with her presentation with the same pediatrician need in our mind and your good lecture. Dr. Anju said, Madam, please.
Thank you, Dr. Sunil. Hello, Dr. Jaideep. I'll just share my screen. Yes, I've heard with a lot of interest, at least Dr. Vaman's terminal few slides, Anurag's entire presentation. As expected, there is going to be a lot of overlap. So I'll quickly go over the facts that have already been covered by my previous speakers, but focus more on, as Dr. Sunil said, what do we expect a pediatrician to do? Okay, so this is on outpatient management. First and foremost thing to realize is very often the parents do not realize that their child is obese. Our cultural milieu is such, very often obesity is equated to health. So many obese children actually do not present primarily for obesity. What do they present for? All the cases that Dr. Anurag has shown us. So they come to us with lipomastia in girls and gynecomastia in boys. They come with micropenis. They come with hirsutism, a manifestation of PCOS. and they come to us with that black line on the neck which never goes when I rub it off. And that's the acanthosis nigricans. So very often parents may not realize, and there are scientific studies which have actually shown that parents don't realize their child's obesity problem. But can we as pediatricians afford to ignore it? No. And that's why I put in these few slides that we must keep in mind that childhood obesity is not a benign disease. So I'll quickly go through some important complications that even childhood obesity can be associated with, just that the pediatrician doesn't shrug his shoulders off when he sees a obese child, even though he's presented with something else. What is the prevalence of hypertension? So this study from in urban adolescents, what was found was in obese adolescents, sustained hypertension was present in as high as 43%. 15.3 in overweight, and in normal BMI 4.5%. So overweight children are nearly 2 times more likely, and obese children almost 3.5 to 5.5 times more likely to be hypertensive than children with normal weight. What about type 2 diabetes? If globally, as the incidence of obesity is increasing, the diabetes is rising in parallel. So the study from Israel in a large number of children and young children, 5 to 12 years of age, and they looked at adolescents with BMI, 5 to 12-year-old children with BMI more than 85th centile, insulin resistance was present in as much as 81% children, and impaired glucose tolerance in 13.5%. Dyslipidemia. And this study again from Turkey, such a high prevalence, nearly 43% of obese children had dyslipidemia. More than 50% had steatohepatitis. So, and obesity is actually recognized as the single most important risk factor for for insulin resistance and cardiovascular disease. And it's a bigger problem for us because these problems are worse in children who were low birth weight, and a lot of our population was actually low birth weight. The epigenetic changes in low birth weight infants are such that their body is genetically programmed to conserve and use energy more efficiently. So when these children are exposed to a diet which is unrestricted, they tend to gain weight faster, and that tends to be all centrally located. And these people are the ones who are even more at risk. Not only that, there are other many complications of childhood obesity: PCOS, steatohepatitis, gallstones, cholelithiasis, obstructive sleep apnea, you name it. And let's not forget the psychosocial aspects. It's actually there is a lot of paradox. When the children are young and they are obese, we tend to find them as cute and sweet. And the same child, when he gets older and he is still obese, he is subjected to stigmatization. People feel that this is a child who has been overindulged with, product of overindulgent parents. There tends to be stigmatization. As a result, there may be poor self-esteem and depression. And this actually makes obesity worsen because these children then don't want to get out of their home and they don't want to exercise, and that worsens the cycle. So, coming now to evaluation. When such a child comes to us in the obesity, please don't ignore him. He actually needs your help. So, what is our objective of evaluation? Well, we want to do history and examination and broadly classify these children into two groups. Is the history and examination broadly all right? Then this child is likely to have what Anurag said, physiological, or I am saying a simple obesity or the nutritional obesity. Or if the history and examination reveals some abnormalities, which we will talk about a little later, the child is likely to have pathological obesity. Next, in a child with simple obesity, we would like to evaluate for comorbidities and manage them accordingly. Whereas if a child has pathological obesity, what is not good? Let us see. A child with attenuated growth velocity should undergo endocrine evaluation. Most of these children, as Anurag had mentioned in his talk, with simple obesity tend to be tall for age. But if along with obesity, the growth velocity is reduced, that means over time his growth line is kind of crossing centiles downwards. Such a child needs endocrine evaluation. If there is a history of CNS injury earlier, think of hypothalamic obesity and pituitary function needs to be evaluated. And if there are neurodevelopmental abnormalities or there is history of severe hyperphagia, such a child requires genetic evaluation. So this is our objective of our initial evaluation. Okay. So simple obesity, primarily imbalance of energy intake and output, multifactorial in origin, a very, very strong role of parental fatness. Actually, parents control the genes of the child, parents control the environment of the child, and it is no surprise that obesity does tend to run in families. And I'm again reiterating the role of fetal and perinatal programming. And this actually decides the children at higher risk of obesity. So any child who is born either with low birth weight or with high birth weight is more likely to be obese. A child where mother is undernourished as well as obese is again at a risk of obesity. A mother where there is a poor weight gain in pregnancy or excessive weight gain in pregnancy is again likely to be obese. So a healthy child is the one who is born to a mother with a optimum nutritional status, who remains healthy during pregnancy and gains a optimum weight. And that is why controlling the perinatal period, focusing on perinatal period is a very important aspect of prevention of childhood obesity, as very nicely brought out in this beautiful WHO report, Ending Childhood Obesity, that came out in 2017. A lot of stress has been given to the perinatal period and maternal health. Moving from simple obesity to pathological obesity, there are some important genetic syndromes. The ones with associated developmental delay. So most important is Prader-Willi. The others which fall in this category are Albright hereditary osteodystrophy and Bardet-Biedl syndrome. There are more, but these are the important ones. Then there are certain monogenic causes of obesity which usually present without developmental delay. And these include the MC4R deficiency, leptin receptor, POMC deficiency, etc. So if we are thinking, when do we suspect these disorders? We suspect these disorders if there is onset of obesity, early onset, the infantile or within the first few years of life, if there is an onset of obesity, if there is an extreme obesity, if there is a high degree of hyperphagia, if there is a developmental delay associated along with the early onset obesity, these are the candidates for genetic testing. And one would like to offer them. Now, these studies are easily available for us in India also. Well, not easily, at a cost they would come, but they are available. The DNA methylation studies and the molecular genetic studies. What about other causes? Beyond the genetic syndromes, the endocrine causes that can lead to obesity are Cushing's syndrome, the Albright's hereditary osteodystrophy, and hypothyroidism. CNS causes, trauma, tumors, post-infectious, and miscellaneous like drugs, immobilization, muscular dystrophy. These are the patients who are restricted to bed and likely to become obese unless their diets are carefully managed. So how to evaluate such a child? Um, the objective of our evaluation is twofold. One, we want to evaluate for etiology of obesity, the one we have covered, simple obesity, pathological, and which kind of pathological obesity. And at the same time, also for the complications or the comorbidities of obesity. So first and foremost, we would like to review all the previous growth records. If they are available, it's a very rare commodity. It's actually rare to find a child coming with the beautiful growth chart that we all love to show in our presentations. Practically, most children don't have. Nevertheless, if a child has them, it's a very, very valuable record. It can show us how the child's weight and height, if that is also available, have tracked over the previous years. Then one would like to review the symptoms. Presence of polydipsia, polyuria, nocturia, nocturnal enuresis, presence of abdominal pain, presence of shortness of breath and exercise intolerance, acne, hirsutism, menstrual abnormalities, snoring, sleep disruption, daytime somnolence, hip, knee, and back pain. I've written the causes, the implied etiology in the brackets here, recurrent severe headache, and constipation, cold intolerance, fatigue. You would realize these slides are all encompassing, they're covering the etiology as well as the effects of obesity. Beyond the present history, the birth history. So what was the birth weight? What was the maternal health like? What was the weight gain during pregnancy? Any maternal sickness? Any feature suggestive of placental insufficiency? Any maternal diabetes? Breastfeeding? Family history of obesity, type 2 diabetes, family history of hypertension, lipids, and heart disease would be important. Developmental delay for the genetic syndromes that we have spoken about. Uh, the next one is tricky. Dietary history and physical activity. Now, this is important from both. Of course, if you're thinking in terms of Prader-Willi, then hyperphagia, food-seeking behavior is important. But beyond that, if you're dealing with simple obesity, this has to be done very, very carefully because it's not very easy to elicit all the components of the diet. The child might typically say what he has for breakfast, lunch, and dinner, but very conveniently omit the snacks that have been taken in between. Plus, when we talk about breakfast, lunch, and dinner, unless specifically asked for how many meals are ordered in or how often do they eat out, these things don't get covered yet they contribute to the bulk of calories. What about, so one needs to look at it very carefully and in a very, very sensitive manner so as not to offend the family. The exercise, the television viewing. So what is the screen time like? What is actually the physical activity of the child? So in effect, what we're trying to see is the balance between what is going in versus what is being spent. Psychological assessment is also needed to look for any eating disorder, presence of depression, the self-esteem, and readiness for a behavior change. Remember, as I said, a lot of time they have not even come to you because they are obese. And they might have come for gynecomastia and they might be perfectly happy, equally unhappy with you when you say gynecomastia will go on its own. What you need to do is lose weight. They have actually not come to you for that. What they want is a magic remedy for the gynecomastia or for the micropenis. So once they realize that all that you need to do is lose weight, half of their motivation for coming to you is gone. So you actually need to see the readiness for behavior change. You need to really assess how ready is the family even to listen to what you're going to say. So examination, anthropometry, that's the beginning. So we do the weight, we height. Dr. Vaman has already spoken to you about the new IIP growth chart, the pediatrician friendly growth chart, where if you plot the weight and height just using the same figures, you don't even need to calculate the BMI, and using this little inset here, you can straight away find out if the child is overweight or obese. And of course, the BMI charts are available for all of us to use. And also, there are apps available which very nicely calculate if you put in the birth date of the child, the date of visit, and weight and height, they will calculate not only the BMI, they will also give you the Z scores. So it is easy to do it. This is the definition of obesity. I think I can happily skip it. It's already been covered in the previous talks, but the charts that we spoke about are based on this. We use WHO standards for children up to 5 years and the Indian standards for children beyond 5 years, and the IAP growth charts developed by Dr. Vaman and his team have nicely combined both these to make the concrete growth charts that we are speaking about. So one should look for hypertension, look for retinitis pigmentosa. We were talking about Barrett-Biedl syndrome, so retinitis pigmentosa, especially in a child who's reaching the second decade of life, retinitis pigmentosa may be obvious. A good head-to-toe examination, body fat distribution, look for features suggestive of Cushing syndrome, moon faces, buffalo hump, a dysmorphic faces for the genetic syndrome. Albright's hereditary osteodystrophy, a child apart from short stature will have small hands and feet, whereas polydactyly is a feature of Barrett-Biedl syndrome. Look for bowing of legs, limp, limited hip range of movements, and look for goiter for hypothyroidism. Just one thing to say here, congenital or acquired hypothyroidism is a seldom a cause for gross obesity. So usually the hypothyroidism, at least in pediatric age group, would cause a growth retardation and associated with a relatively higher BMI or a relatively higher weight for height. Gross obesity only ascribable to hypothyroidism is rare. Keep that in mind before labeling any child with the obese child with a little elevation in TSH as hypothyroidism. Anurag had very nicely presented a case on this. Look at the skin. These are the violaceous stria suggestive of Cushing syndrome, the acanthosis nigricans in the neck and in the axilla suggestive of insulin resistance. Look at the liver for liver size and tenderness for fatty liver disease. Uh, Good to see the pubertal staging because hypogonadism may be present in some genetic syndromes, whereas and a much more common so-called apparent micro penis is actually just a normal penis and buried in the suprapubic fat. And look for undescended testes again found in Prader-Willi syndrome. So in general, if the child looks okay, has a normal development, stature is relatively tall for age, but BMI is even higher. Higher Z score for BMI as compared to height, which height for age Z score, with a normal development, no physical dysmorphism, and a compatible dietary and lifestyle pattern is likely to be having a simple obesity. Whereas a child with associated short stature, a child with delayed development, a child with dysmorphic faces, any history suggestive of previous CNS disease, early onset severe obesity, and features suggestive of Cushing syndrome is likely to be pathological cause of obesity. So this kind of a growth chart where if you see this, this is the weight and this is the height. The height along the 97th centile and weight beyond the 97th centile typically shows a child with simple obesity. Whereas if you look at this growth chart, this is the chart of a child with Cushing syndrome who was earlier having his weight along the 50th centile and height also along the 50th centile. But what has happened around the age of 7 years is while the weight has progressively gone up, the growth velocity has declined. So this kind of a growth chart, the second one can never be normal. And this indicates a pathological obesity. And this is just to share with you a child with the Prader-Willi syndrome, 8-year-old, he has hyperphagia, with short stature, delayed development, poor school performance, a small penis with undescended testes. You can see that the test from the poorly formed scrotum that the testes are undescended, and a generalized hypotonia, very characteristic picture of a Prader-Willi syndrome. Let's look at another child. This fellow is 13-year-old. He has a history of weight gain and poor height gain. For 2 years, he has a rounding and redness of face for the last 8 months. He has acne for the same duration with proximal muscle weakness and striae over the trunk. And you can see this striae here on the thighs. On examination, he's short, he's obese, he has hypertension, he has acne, he has striae. In short, he's a book picture of Cushing syndrome. So once we have seen a child with Cushing syndrome, what investigations do we need to do? What do we need to do in all obese children? We need to do a fasting glucose and we need to do a post 2-hour postprandial glucose. One would like to look for frank diabetes or one would like to look for impaired glucose tolerance. One must measure the ALT levels and even a mild elevation of ALT beyond 25 and 22 in boys and girls respectively is considered to be elevated. And one would like to look at the fasting lipid panel to pick up dyslipidemia. This is something that should be done in all obese children, apart from, of course, the clinical assessment that we have spoken about earlier, including hypertension. These tests are done for selected subjects, and these include fasting insulin, like which include hirsutism or acanthosis nigricans, free testosterone, especially in presence of features of oligomenorrhea, acne, and hirsutism. Um, if we suspect hypothyroidism based on slowing of growth velocity, excessive dry skin, clinical features of hypothyroidism, one may consider a thyroid profile. Looking like Cushing's, 24-hour urinary free cortisol. Prader-Willi suspected from history and examination, DNA methylation studies, any dysmorphism, first karyotype, and molecular studies if there are significant developmental delay present or other features of the syndromic obesity, as we have earlier spoken about, are present. In a child with suggestive obstructive sleep apnea, polysomnography may be indicated, and a child with elevated ALT would be a candidate for liver fibroscan. So these investigations are not done for every child, but offered on a case-to-case basis as required. Having done that, how do we treat them? Well, the medical goals are resolution or at least improvement of obesity sequelae like hypertension, dyslipidemia, and impaired blood glucose tolerance or diabetes. One would like to do a weight maintenance for overweight and obese children under 6 years, and overweight older children and adolescents, at least this much. And one would attempt weight loss only for obese children beyond 6 years with associated comorbidities. Okay. And what is this is our treatment goal. And what is really important is a behavioral change, that is acquiring and maintaining healthy weight management behavior. Not very easy, but their managing childhood obesity never has been easy. So, especially children with morbid obesity are especially at risk. And who are at morbid obesity? BMI beyond the 99 centile are especially at high risk of complications, and they should receive prompt attention. What is our aim of therapy? Well, aim is not just one time weight loss, aim is a lifelong weight control. We would like to increase the decrease, and I'm of course talking about simple obesity here, decrease the energy intake while allowing and normal growth. And if weight reduction is planned, and remember we talked about weight reduction only in an obese child beyond 6 years of age, it requires a serious commitment of all involved. By all involved, I mean the child, the family, and the caretaking physician. It's monitored very carefully. You want to have a gradual weight loss for children, not more than 0.5 kg per month in children less than 12 years, and one would not exceed 1 kg per week for children, even if they are obese. It has to be very carefully done, and this is something we would not really like a pediatrician to be doing under his own clinic. One can actually refer these children who actually to for a expert care under people who have the expertise in handling them. Final goal is trying to achieve a BMI of less than 85th centile under constant monitoring. What is important is to avoid weight cycling, something which is very common. A child, it's easy to get a child and family motivated once, but difficult to maintain that motivation. And therefore, the cycle of weight loss and re-weight gain, every such cycle makes the subsequent weight loss even less effective. And so it really needs an individualized plan to be made along with the family and the child according to the child's current lifestyle and eating pattern, taking into account their social, cultural, economic situation, the intellect, and the degree of motivation. Individualized plan needs to be made. So the therapeutic strategies are around four important pillars: the nutrition education, most important; regular planned exercise, again very important; lifestyle and behavior modification; and psychological family therapy. These are the four important I've put queries here, and I'm really not going to take them up in this talk at all, because that's not what we want our colleagues, our friends, the pediatricians to be doing. What we should be doing is explaining the principles of diet modification. The principles remain the same and everybody knows them. The difficulty is in implementing them. So same nutritional principles as those for other healthy children. One should actually avoid the use of term on diet, which has very temporary connotations. And likewise, one should actually avoid the over obsession with calorie counting. Rather, one should stress on healthy eating. So, and severe dietary restrictions are actually to be avoided because they actually lead to loss of lean body mass with nutritional deficiencies and other unphysiological changes. Besides, they are unsustainable. They may lead to repeated weight loss failures and non-compliance, certainly do not promote a healthy eating behavior. And further, safety and long-term benefits are not documented in children. So we don't want to advise severe dietary restriction. The diet therapy it would be good to involve an experienced dietitian if the actually it involves a serious commitment. So on part of the family and the physician, it will be good to have a dietitian on board, an individualized diet plan in discussion with the child and family. Simple means like reducing fat and sugar intake, avoiding snack or mid-meal snacks, or replacing them with low-calorie snacks, increasing the fiber content, ensuring family participation are some of the principles. Exercise. Somebody asked many exercise, how much exercise, what exercise. What WHO recommends is 60 minutes of at least moderate to vigorous physical activity, at least 5 days a week. So, what we want is the children, they don't need to do 60 minutes at one go. It can be multiple bouts. So, there could be one bout in school, one bout after coming back home, and maybe one bout later in the evening. So, it could be in various bouts, and it should be activities. For it to be successful, it has to be some activity that the child finds fun. He will never do it if it's a drudgery. So, every child, his own, let them find their own sport, let them what is possible for them, what is available to them. It should be fun, it should be something that is sustainable. And behavior modification and social support is actually the backbone of an effective weight loss program. We need to actually convince the entire family regarding the need for weight loss and ensure the participation of the entire family. Other, while at it, other obese family members also need to be encouraged to lose weight. One can encourage self, some goal setting, some promotion, little positive reinforcement techniques. This, as a family, if one does it, it is possible. Restricting sedentary activities and screen time to a maximum of 2 hours per day. And this is very difficult in the current COVID times, but well, this is what one can aim and do. So, when should a pediatrician refer a child for further management, maybe to an endocrinologist? Suspicion of a pathological cause for obesity, Cushing syndrome, genetic syndrome, CNS involvement, etc. Obesity with associated comorbidities like abnormalities of glucose homeostasis, dyslipidemia, PCOS, sleep disorder, or orthopedic problems. Failure of obesity management